Hello, everybody, and welcome to the AHA podcast, Advocate Health Advisors. One a day early this week because there's been some new news hot off the presses. In fact, it's not even off the presses. Alyssa, what are you hearing out there about broker compensation?
Yeah, well, late yesterday, and when I say late, I mean after 5 p.m. yesterday, we started seeing out there that CMS released their 2027 agent and broker compensation rules, their memo that comes out around this time every year. It's actually a little on the earlier side this year. Sometimes it's in mid-June, but they released it with the 2027 rates, commission rates for agents.
Wow. And is that good news or what's
So, yes, I think at first glance it is good news because the compensation rate for agents for the first year plan sales nationally is going up to $725. And in other states like California, New Jersey, it's going up to 902. Connecticut, Pennsylvania, and DC, it's 816. So it's an increase from 2026, which is great news for agents.
well, that's good. Now, is this up on the CMS website?
No, not as of yet. We keep checking throughout the day. The carriers get a hold of it first, and then they should put it out there on the HPMS website here. Hopefully today we'll have the official memo. We basically have it in full. It's 4 pages, but it's not officially out there for the public.
I've seen a lot of screenshots of,
Yes.
somebody saw it and took a picture and
Yes.
shared it with somebody else. Well, you gotta appreciate the eagerness and the, thirst for information. I think part of a broker's job description is, detective. So Jacqueline, is the new number the headline, or, was that the only thing in the memo, or was there a little bit more?
Yeah, I think there's other parts of the memo that, drew some attention. We know the fair market value is the ceiling that CMS sets every year for the next contract plan, but then the carriers actually determine what they're going to pay. And then what we see for most part is that carriers, when they as required by the federal registrar, they're actually supposed to, by the end of the last Friday of July, let CMS know if they intend to use agent brokers, whether they're including if they're independent, employed, captive, and they usually provide a range of 0 to the fair market value ceiling. And so it's interesting because if you look at the memo, there's some expanded voluntary data collection. So CMS is now pushing for greater transparency, and they're asking the carriers on a voluntary basis starting the end of this month to report additional information on compensation, including if it is going to be 0, if it's going to be $1, they want the actual specific amount by plan. So that's really interesting, and that's new for carriers to be reporting on. And that's, published by CMS on the site today under agent broker compensation. And we've been looking at the 2026 data to really see what that looks like.
Well, that's interesting. Alyssa, you said they could pay up to 700 plus dollars, but Jacqueline, what you're telling me is they could also just pay 0.
Right. If they file that, they usually do 0 to the ceiling. So they even put PDP, commissions out there too. So I think, agents are reading that. But if you read it, there's a lot of good things in there regarding about some increased transparency. I think CMS wants to better understand exactly what carriers are paying, not just making sure that they're meeting, the ceilings that they set.
Well, isn't there also some information in there about suppressing or not suppressing plans and the decision support tools?
Yep, there's a part in there regarding enrollment form accessibility. So it's interesting because if you read it, CMS is signaling that suppressing or complicating enrollment forms for beneficiaries may be considered misleading or deceptive under federal regulations. We saw a lot of that happening over the last AEP and into 2026 of enrollment decision tools, not showing plans or there's additional prompts. So it's interesting. CMS is watching this, and I'm interested how carriers will respond to this, coming into 2027.
What do you think, Alyssa?
Yeah, it's definitely interesting. I think that, what we saw happening last year and actually earlier this year too is that plans were going non-commissionable in the middle of the year or throughout the year. Some of the state departments of insurance got involved and were sort of basically saying, how can that be fair, especially to the beneficiary when that could lead to steering to certain plans that do pay commissions. And then by hiding those enrollments, hiding the option to enroll on the enrollment platforms, again, it does a disservice to the beneficiary. It could lead to steering to plans. So I think those state departments of insurance getting involved really drew the attention of CMS to this and put more of a spotlight on it. So I think it kinda just shows where CMS is thinking about this as far as
You think steering is the right word? Like, if the carrier says, "I'm not paying you commissions," which is separate than
Mhm.
suppressing it, right? I think carriers
Right.
have the right, to file that they're not gonna pay commissions. So, I mean, we could probably talk a little bit in a minute about doing it a day before AEP.
Yeah.
What the time frame and, putting, no net versus some net, but, I don't know, steering has a very specific, meaning in terms of, a bad behavior, at least in the state of Florida and many other states. So I don't know if they're not paying, I think it's the agent's prerogative to put them on that plan or not. The carrier very specifically does not want you to put people on a plan, but the law, the Medicare, the law says to give people a paraphrase, it says people should have the ability to choose a plan that is in their best interest, right? That's for them, and then all the CMS rules are the guidelines around that. So I think that when they take it out of the decision support tool, that's against CMS's wishes. So the carriers are allowed to not pay a commission as it stands today. I think we'll see some more language around that in the 2028 rule. But it really comes down to the individual agent and what they feel is right and what they're willing to do. If a carrier isn't paying a commission, they're doing that for a reason. And we talked on the last episode about that. But I also think that there is no service in the plan. Look at the PDPs. Some people spend a lot of time, even though they don't get a commission on the PDP, because it's the right thing to do, but they're willing to spend 2 or 3 hours. I just saw Jacqueline the other day help a couple, and she probably spent a total of 8 hours and 3 conversations and 20 different drugs between the couple. But other people say, "Here's the website," right? You can enroll. I don't think either one of them are wrong, right? It just is your situation. I don't think that the carriers or the government should put people in a position where they have to work for free, to do the right thing. And so hopefully we'll see some stability. Um, but it's a hot topic. And then Jacqueline, I want to go to Jennifer, and then I want to go back to you on how many health plans there are and what they use. Jennifer, what are you hearing on the whole debate? Commission, not commission? How are you seeing people handle that?
Yeah. Well, I don't have a crystal ball, but seeing CMS put out these little thought process in there is really, I think, telling because I think that there's going to be maybe some things that could come out in the future on future CMS rules or whatnot. I mean, there's been a lot of noise to the point you guys just made with a lot of the organizations and agents complaining about the non-commissionable stuff. But we know that the carriers are doing this as a last resort because they're not profitable in these plans. Personally, I feel like the carriers should build in um, the money and structure to be able to pay a broker for a PDP plan. Just charge put that into the premium or somehow into the benefit because agents are doing the work and they add value there and they're doing the education. So it just becomes a scenario where, and I know they just finished their plan designs, all the carriers, but I think that they need to really, when they went into those bids, design it around with a broker in mind. I've seen statistics out there that say, what was it, like 90% of enrollments are done by an independent broker. I mean, the brokers are adding value and they need to be added into the equation. And this is the message we should send. And I think that it's a very complex situation going on. Uh, because we never saw carriers making things non-commissionable to this level before. But it really is it is a sign when you see that happening that the carrier just doesn't want the enrollment. And they're not necessarily like I don't know about the steering thing. I think that gets pretty extreme. I think that the carriers are still allowing a way to enroll. They can do that. They're not just suppressing it on the carrier enrollment websites or CMS. But ultimately, you know, I would like to see them stabilize. I would like to see the carriers build it in that put a plan out that they can pay a broker that they want sold.
Yeah.
Period. Yeah.
Well, yeah, I think we all want that. And I think in the carrier's defense, right, they got a lot of unexpected things over between the IRA, the MER, the post-COVID activity. But you're right. If you're advising someone and you're helping them with, pre-enrollment activities and education and expectation, enrollment activities, post-enrollment, the service component of this job grows more and more every year. And we're vital. Both the agent and the FMO are like traffic cops, right? It's like when I was in the military, battlefield circulation and control. You're helping resolve gaps and barriers, right? And we do that every day, and we add a terrific amount of value for the infrastructure we have. And there's countless stories where a particular situation wouldn't have been resolved if the FMO didn't get involved. Like outside of commissions, Jacqueline just had a case the other day. What was the rule if they have a plan and they've got a care plan, they're
Continuity of
entitled to
coverage,
service? Yeah.
continuity of care. Yep.
The CMS made a continuity of care rule that basically says if you've got a care plan in place, and then you change insurance carriers, that they still need to honor that, even if there's a network discrepancy or something like that, right? So you have continuity of care, which is a big deal, especially when you've got chronic conditions or multiple chronic conditions. And so the, the I think the general thought is that everybody thinks that the carriers know this and do that, but that isn't what happens. What happens is we had a client who went to the hospital. They got denied. It's a longer story because they actually got denied a couple other times before they even made it to see their oncologist. And so then they said, "Oh, we're not going to see you." And so we got the call back, through the beneficiary and the broker, which we help, because we've got the horsepower to break some bigger barriers and bridge some wider gaps, right? Because of the nature of being an FMO. And so it turns out that they just said, "No, you're not covered. You got to go somewhere else." And we came back and said, "No, this is CMS's rule." So the carriers don't always know CMS's rule, and so that's where we come in as a safety net. So FMOs are consumer protection. We not only support the broker, but we've got the horsepower to kick it up a notch. So we actually are in the balancing business between what's best for the beneficiary, but also when CMS, I mean, when the carrier and the provider are pointing the finger at each other for some reason or working through a logjam, we can be instrumental in that. So that's a big deal. But getting back to commissions, because Jennifer, you said something about the 90% of the brokers. Jacqueline, how many different health plans are out there and how many of them use brokers? Because I see all this confusing information that says, oh, a third, these numbers. But from my education and experience, over 90% of Medicare Advantage enrollments are done by a broker. Now, they might be an e-broker, they might be a community-based broker, they might be an employee of the company, they might be a 1099 contractor, but everybody has to have an insurance license and to be appointed. So help me understand that, because the way I see it, almost everybody in Medicare Advantage deals with a licensed professional.
Yeah, I think when we spoke with a lot of carriers and executives, I think most of us will say it's over 90% of agent broker assistance or use in an enrollment. One of the things that's interesting too, as we are also analyzing this more closely, CMS does publish files of what the health plans report to them every year for the use of agent broker compensation. That is a requirement. And by the last Friday of July, they have to report that use for 2027. And so just looking at the plans, because there's different ways to count. There's, in terms of specific total MA plan offerings for 2026, there is 5,556 specific individual plans. Also, that rolls up to 171 parent organizations. There's likely over 300 MA organizations overall, but they roll up to 171, and they
Let's break that down a little bit because you're so smart. I can't quite keep up with that. So CMS contracts with they have a contract with a health plan, right?
yes,
And that's like what we would call top of hierarchy as a FMO. And
yes,
so there's 167 of those contracts out there, right? Plus or
yes,
minus. Okay. And then that contract is unique as an identifier to CMS and an entity, but that entity could have sub entities, right?
yes, that's correct.
So what's an example of that, Alyssa or Jennifer?
Maybe
Like
like Humana owns Care Plus, and so the parent organization's Humana, but they have
Humana,
Care Plus, or
Elevance,
Elevance is one where they own a lot of different entities. They have
Right.
Anthem,
Centennian.
Amerigroup. So,
Right. So
yeah,
now
WellCare has.
you're getting into the brands and you're getting into the other organizations, but they're under that contract still, right?
yes,
And then, Jacqueline, what you were saying about 5,000 plus plans, which are not in all counties, more than 3,000 counties, but whatever geographic footprint they want, county by county, state by state, year by year, they would have plans that are different types of HMOs and PPOs and C-SNPs and D-SNPs,
that's
right?
correct. That encompasses all of those across the nation.
So, Jennifer, do you think 5,000 plans is too many? Because it sounds like that could be overwhelming, but then, different people have different needs. There's 65 million beneficiaries plus. So, is that too many or is that just right? Or what do we think about that?
I don't know. That's interesting because after doing this for 21 years, you have these carriers that come forward each AP and they're like, we're going to give a lot of different types of choices because there's a lot of different types of beneficiaries that have different needs. And then another bid season, they come through and they go, we're going to simplify it. We're going to have one plan that's going to be across, one type of plan across each area. So honestly, I think it's okay that they make it complicated. And here's why, because people do have individual needs, and it just makes there be more need for an independent, licensed, quality, hopefully community-based independent agent to help them make the decision. If they made it super easy and they just made it where everybody would just go and roll on a website, they would already be happening. But the truth is, this is really complex. And, that's why. So personally, I don't mind there being lots of different choices. The information is easier to process these days anyway. We can get it at our fingertips and help people. So,
Well, first of all, I don't think they make it complicated. I think you said it well the second time, which is it's complicated stuff, right? Diseases attack the entire body. Doctors are organized around the parts of the body that they specialize on. And there's a whole bunch of non-clinical things, environmental and policy wise that impact health outcomes. So when you get all that together and try to be preventative and try to talk across the community with each person, right? Each person with their own unique fingerprint, their own unique DNA, their own unique, retina or their iris, it's complicated stuff. And science, medical knowledge is doubling every year or sooner. So more stuff is possible. People are getting older, people are getting sicker. So it's complicated work. So I mean, Jennifer, I know, like shoes. I mean, what if shoes came in just medium? What if shoes were small, medium, and large, right? I mean,
yeah.
that wouldn't be good. A good fit matters, right? Especially when it's something that could save your life or prevent you from getting sick. Look at the grocery store. How many different types of cereal are on the cereal aisle? I used to know the number to that, but it's a lot, right? And during COVID, if they didn't have my kind of cereal, I ate eggs. I ate something else, right? Because then that's just breakfast. I mean, that's not something that can save your life. So Jacqueline, of the plans, they list that out, right? You found that information and you've synthesized it. And then how about with the commissions or not commissionable? Are we going to be able to see what plans are actually paying aside from the ones that said they were going to file?
Yeah, so right now for 2026, because that's out, they do report on here the required fields. The minimum and maximum right now are being reported, and if they intend to use things like referral fees, with the minimum and maximum that they plan to pay agents and brokers for renewal initial year. So some pretty basic columns in this report. Right now for 2026, the use of agent and brokers for those 5,500 plans is over 99%. So most filed plans coming out for 2026 intended to use agent brokers. Looking to at the 171 parent organizations, over 97%.
So you're saying as all those plans roll up to those brands that roll up to the actual 167 contracts that exist with CMS, which is publicly available on their website, you're saying that over 99% of them have filed to use a broker in some form or fashion, whether that's a 1099, independent state licensed broker, or an employee as a W-2, or an exclusive arrangement. You're saying that 99 point something percent
Yes,
they've filed with the government to have the right to do that.
yes, they did.
Well, that's a lot more than a third, isn't it?
Yes, it sure is. And they also break it out by independent agents. For all that's also over 5,500 plans and 99%. Which is really significant, and right now, based on that memo that's coming out, it sounds like there's going to be a few more columns being added to this report, including what the exact amount is for those plans. And plans can update that all during the year too for 2027. And it looks like CMS is they're saying voluntary, but I don't know if they're being voluntold by this memo, because they're saying that they're going to monitor that and going to analyze that data a little bit more closely.
Well, I think that, Dr. Oz, first of all, I think the CMS leadership team is incredible, right? I've never seen such a level of professionalism and collaboration. And I think they've really brought the best out of the career folks. A lot of people are appointed, right? The senior leadership team kind of comes and goes with the administration. But I think they've done a great job of inspiring and capturing the talent of the professionals that are there for, 10 and 15 years. So they see administrations come and go. And I see that with my own eyes because, they have a trades working group that we participate in. And, they're really interested in doing the right thing for the right reason. Also, though, what Dr. Oz and his team have done that is, I think, brilliant is he calls himself a convener, right? He's using the authority of his office to say, I want you to come together as an industry and work it out. And he very many people have said this in many, public forums. It's like, if you don't work it out, I've got the wherewithal to come in and use rulemaking and other, powers that the government has, or even lawmaking if necessary. But why not just work it out yourself, right? We've got important work to do. We've got a lot. We've got 5 million people or so coming in every year. Thank goodness people are living longer and they're living better. So there's actually, a shortage of agents. Like we've got more work to do than we have resources to do it. So to me, the name of the game is we got to get the most amount of wellness out of each healthcare dollar available. And that's a little bit of a rub. It sounds good, but the government has a budget, right? And so that budget has to get approved. So they're a little more on the cost side. They're trying to make the trust fund and other things work to be as long lasting as they can. But if they don't go onto the innovation side and think about wellness, because Medicare Advantage is definitely about prevention beats cure, so that you can be short-sighted in your policy making to only worry about the cost, but you have to think about the long-term implications of your policy. And that's where I think we can innovate and all work together. And that's what I think Dr. Oz and his team are doing. I think they've set the culture and the foundation and the environment because we're talking to each other. I've been taught, we've met, of course, Dr. Oz, we've met Joe Albanese, we've met all sorts of great people who are out there every day bringing it. I mean, there's just a ton of senior leaders going out to broker events, going out to CMS quality events. And so I'll put it back to you, Jennifer. What are you seeing on the day-to-day calls now? What's the last five, GA conversations you had?
Well, I mean, this one's a hot topic because, we just got the CMS rate released in the last 24 hours. So that's been the topic for the last 24 hours. Also the topic about what plans might look like for 2027. So we're keeping our ears and eyes open on what we might hear on expansions or any plan exits and stuff like that.
In some cases, they cut commissions, but didn't Humana and others say We're going to pull the
Think
ancillary
there was a
benefits.
earnings call or
Yeah.
an investor call or something where they kind of alluded to that. They're going to be pretty quiet about exactly what's going on, for as long as they can. So we'll just kind of gather and read between the tea leaves, if you will, so that we can educate and really just for agents to be ready for AEP. I think, going back to what you said about the information that CMS is asking to collect, and Jacqueline, you alluded to maybe a few extra columns that are going to be on that sheet. In some ways, I think like an independent broker and even an FMO that's working in a particular area that knows the lay of the land for how many different carriers are there and what carriers are doing and has gone non-commissionable. Individual carriers are just doing what's good for them, but the big picture of what might be happening in that market could be best served. And because I would have liked to have seen, for example, last year in the state of Vermont, there were no MA carriers in many of the counties there. We saw that happening, and I kept thinking like if CMS could create an environment that would incentivize the carriers to come in and put a plan in there would be options for those members. So I think to the point that there could be information collected or shared that doesn't give away secrets because the carriers are competing with each other, but just in a way that it gives options to members. To your point, Darwin, Medicare Advantage works well. It's a coordinated care model. I'm very bullish on it. They are just to this point where they've lost money and had to pull back, so they can't get out there and put new plans out there. And so we need there to be options for members in this everywhere. And, I think that, collecting information is great. And again, like I said, they need to put plans out that they can pay commission and involve the broker. So
Yeah. No, I think you're exactly right. And, Medicare Advantage itself is a virtuous cycle, but sometimes, one administration to another administration, the stability isn't there. So, in the previous administration, CMS was a fortress, right? People wouldn't talk to me. We tried many times in many ways, and it just wasn't the same environment. And so the things that you want to talk about and being proactive so that beneficiaries have choice and that carriers compete with each other to create value, which benefits the beneficiary, which allows the carriers, who do a better job to get more money. If they have more profit, they can keep their 3% and then they can invest the other revenue into richer benefit structures, right? So it's a virtuous cycle. And so you're totally right. We need to do that. I think that comes through collaboration, and I think there was a series of, carriers, especially the publicly traded ones, they have an obligation to their shareholders, so they can't just lose money if they have to choose between losing money and curtailing the plan. But where I think that takes us in the future is what a friend of mine called the Swiss cheese model, right? So carriers are gonna define the market very clearly where they want to win, and they're going to go there and they're going to win where they win. But there's going to be places that they have to exit because they can't win because they're either low or they're medium. And so I think you'll still see after we get through, I think we have another AEP of disruption, but I think that we've laid a foundation now, to not repeat our mistakes. And so I think the beneficiary is going to be better off because the private sector is really good at innovating. They're really good at customer service. And the government, the federal government, is really good at being dependable. They're trustworthy and they're dependable. And I think you get the best of both worlds with Medicare Advantage. And so where consumers or beneficiaries, same thing, where they're going to benefit is they'll take these innovations and they'll take the competitive nature of the market. And the current administration is suggesting we put our own guardrails in place. And of course, I'm working with them now, do a little commercial for the Medicare Collective. So under NAFA, we've got the, FMO leadership now for the first time ever working together in a collective, right? In a group. And we're talking to carriers, we're talking to CMS, and we're trying to represent the interest of the brokers and the great work that they do in the communities on an everyday basis.
which I think is awesome because, FMOs are always competing with each other. We always make that analogy. We're like kicking each other's butt on the football field. But outside of the football field, it's for the betterment of the league. So I'm proud to see that, Darwin, you and Jacqueline have been participating in that. And there's just like really good stuff happening. And really, if we elevate the whole industry, it'll work. on your Swiss cheese analogy where you say, they're going to leave where it's not good. Unfortunately, what I'm seeing is that it's the same places that the same, all the carriers in those same places are exiting, and then there's no option. And so that really leaves back to what can we do to help? Well, what we can do is just make sure that when there is a plan, we work with the carrier to understand how we can put people, help the members be on the plans efficiently, to use the plans the right way, right? Like if, not go to the hospital when there's an urgent care, or things like that cost the system more money. And then just be, the higher quality brokers, right? Like, and I'd love for Alyssa to talk about the things that make a high quality broker, because she's the compliance person and knows the most about that. But like, that's where we got to get to when we have
Yeah.
call centers that are just enrolling people over the phone in the plan, and it's not the right plan, and then they just disenroll with the short term disenrollment. That's a problem. So
Well, don't disparage the call centers, although there were a few that really epitomize that. But I think you hit the nail on the head, Jennifer. The way that we can help, and that very few people know, is that we impact the education of how to use the plan, and we unlock the benefits in the plan, and we support the broker because the broker can only do so much, and they've got the minimum that they can do, but we've got ways that we can help too. And so what happens is, by showing them the right way to use the plan and being there to help them use the plan in the way it was intended, that unlocks new value. But those are all preventative in nature. And that takes people away from going to the emergency room when they don't need to go to the emergency room. Dr. Oz says that bad care is the worst kind of care, because you only not only have to do the care and pay for it, you have to go back and fix it. He said that 1 in 4 people that goes into the emergency room has some harm done. So, we can look up the quality ratings of the hospital. We can look up the quality ratings of the health plan. We can help with grievances and appeals. And so in those markets, those hard markets, we can more vigilantly, we can do HRAs. The carriers need to pay us to do HRAs or HRAs plus, because the margins have been eroding for some time. So we can't subsidize stuff anymore than the way that we used to. I used to use the PDP commissions to pay for other services. Now, the PDP commissions have gone away, right? And now we don't get paid if an agent does an HRA, but they want us to encourage agents to do HRAs. But, so it's got to work for everybody. But Alyssa, Jennifer had asked you about some of the metrics, and the last thing, Jennifer, it comes back to the quality metrics. So it doesn't matter what the distribution channel is, but whatever channel you use, the beneficiary shouldn't suffer a loss of quality or a low or inferior experience. And it's not profitable for the carrier if they have low quality metrics across the board. And that's something that's going to come out in the wash really as we speak. Alyssa, bring us home with the highlights.
Yeah. Well, when you talk about the quality metrics, I think that's going to be a huge area of focus for the carriers. I mean, it has been for CMS, and the pressures come down on the carriers, which then trickles down to us and trickles down to the agents. And it's a message that we've been, shouting from the rooftops for forever. But a couple of the major key factors that I think carriers are going to be putting under a microscope or in the spotlight is rapid disenrollments. Like Jennifer just mentioned, short-term disenrollments, or what they call rapid disenrollments. That's when somebody switches plans or falls off the plan voluntarily within the first 3 months after the effective date. That's a rapid disenrollment. We talk about stability, and that if a person is put on a plan that's not appropriate for them and they end up voluntarily disenrolling to switch, obviously that's not stable and that's not good. Could mean that a proper needs analysis wasn't done. So rapid disenrollment rate is something that carriers are going to be looking at, and we're also going to be, working with our agents on, just to make sure that they're maintaining good thresholds. Accretion rate, that's when an app is submitted and it goes through CMS approval. If it doesn't accrete, that means the person wasn't eligible for whatever reason. Could be like a dual plan, a D-SNP plan, and the member didn't have the proper level of Medicaid for it, or a chronic condition plan and they didn't actually qualify for that chronic condition. Something like that would affect the accretion rate. And again, it speaks to suitability, right? It wasn't a suitable plan for that person. And then, of course, CTMs, which is complaints to Medicare, when someone calls Medicare and complains, and then allegations that are directly to the carrier. So those are just some of the top quality metrics that we're focused on. And, You had asked Jennifer about what agents are talking about, and I can tell you on our agent care team now that we're into June, we're getting a lot of questions about when certifications are going to roll out. HIP for 2027 is coming out June 22nd, and then quite a few carriers are following suit, opening up their certification windows on June 23rd. So we'll be jumping on those. I know a lot of our agents will too, right away when they open.
Yeah. Well, thanks, Alyssa. I do want to make a comment about the quality. And so, I'm seeing CMS um, taking advantage of the authority they have over the plans, right? CMS manages the plans, and the plans are contracted, and they have authority over the individual agent commissions to make sure that there's goal alignment. And I think that working through the carriers, CMS is going to be able to bring best practices to bear, and they're going to be able to kind of do what we do internally, right? We see what works in one area and we see if it works in another area. But there's got to be guardrails, and I think that the metrics and I would add complaints to the plan. I think we need to modify the definition of a complaint to Medicare, because I think that Medicare probably feels like all complaints are valid when only a small portion are actually valid. So we want to make sure it's really a complaint. Uh, I think we should add complaints to plans, because beneficiaries should have a chance to speak about their experience at many levels. They should be able to tell their broker. In my opinion, most of those things should get resolved by a good broker. They should be able to tell the plan. They should be able to tell the government, at CMS. So we want them to have a vehicle to have their voice heard. But I think that you have to take them in their entirety. And so, just to be devil's advocate, you could have a service area reduction that you didn't know about, have just put someone on a plan, and then you have a rapid disenrollment. But when you take accretion and you take rapid disenrollment, you take annual retention, you take complaints to the plan and complaints to Medicare, when you combine that as a snapshot, then because if they're pegged out of the norms in all those areas, that's a sign that other things didn't go right, that are the leading indicators of quality. Those are still actually lagging indicators of quality. But like you alluded to, if you didn't do a good needs analysis, if you threw too much information at them at one time, and you were talking about complaints to Medicare with me the other day, and you were saying, there's reasons that people have been unfounded, yet they still complain. And one of them you said was you just overwhelmed them with information, right?
Data dumping.
Data dumping. Yeah. And so you didn't do anything wrong, but you didn't get it right either. And so there's ways to learn in there. But I think in the carriers that I've spoken with, which are many, they're open to that. They're all creating their own metrics, which is great, and they should. But I would encourage all of them, and I've asked, and I'm asking CMS to encourage this, because if they use those five and track those five, we could then come up with industry standards. And if you're too many standard deviations away from the baseline, and then we know to go look, and there's corrective training or other things that we need to do. And the carriers also said, make sure that you do it by plan type, right? So if it's a D-SNP plan and an agent who sells D-SNP for a living in, say, Louisiana, well, maybe that's different than a PPO in Northern California, right? So we want to make sure that we're looking at some of the nuances. But if we could just get those five, we would have a view across all the carriers. Because in the old days, someone might sell with one carrier and then get in trouble and they would lose their contract, but then they would pop up for another carrier. So if we don't kind of have that central view, that's a unit of measure that's across carriers. So if Humana makes one set of metrics and United makes another set of metrics, and then Aetna makes still a third set, we know within those organizations how people stack up, but we can't stack up across organizations, which is really what we want to do, so that we can take out the bad apples and celebrate the good ones. But we're running a little long today, but there's always so much good stuff to talk about. Thank you so much for being here, and thanks for listening to the AHA podcast.